Welcome to Health or Consequences, a monthly podcast by Mass Inc. and Commonwealth Magazine. My name's John McDonough. I'm with the Harvard Chan School of Public Health in Boston. And my co-host is Paul Haddis, formerly of the Tufts University School of Medicine, now with the Lown Institute. And we are happy to welcome you. Today, we're going to be considering whether Massachusetts should learn anything from the Maryland healthcare cost control model. Does Maryland have anything to teach Massachusetts about how to do a better job controlling costs, particularly as people are starting to look at some weaknesses in the model that we've had for roughly the past 9 to 10 years now? Our guest, we couldn't have had a better person, is Dr. Josh Sharfstein from the Johns Hopkins Bloomberg School of Public Health in Baltimore. Dr. Sharfstein is a graduate of Harvard Medical School in 1996. He worked at Boston City Hospital with the eminent Dr. Barry Zuckerman back in the late 1980s and so forth. Right now, he's the Vice Dean for Public Health Practice and Community Engagement at Johns Hopkins. He's also director of the Bloomberg American Health Initiative and a professor of practice in their Department of Health Policy and Management. Previously, he served as secretary of the Maryland Department of Health and Mental Hygiene, and principal deputy commissioner at the U.S. Food and Drug Administration, as well as commissioner of public health for Baltimore City, and also a long-serving health policy advisor for Congressman Henry Waxman, one of the legends of health policy in the United States over many, many years. So thank you, Josh, for being with us. It's a real pleasure to welcome you. And I'm going to turn it over to my colleague, Paul Haddis.
Josh, let me add my words of welcome. Never have we had probably such an informed guest on health policy. So we really do look forward to this conversation today. For our podcast audience, perhaps we can get started by briefly outlining sort of a little bit about the history and evolution of the Maryland approach, which we often call here, at least in refer to it as the rate setting approach in healthcare, including its evolution to include hospital global budgets, which I believe went into effect in 2019. So please share that with our audience, if you would.
Sure, and thanks to both of you for having me and for Massachusetts paying a little bit of attention to the old line state, Maryland. So Maryland has had rate setting since the late 1970s. And of course, as someone from public health, I think of healthcare policy, not just about controlling costs, but also about improving outcomes and enhancing the health of the population. So I'll be talking about that alongside controlling costs. But basically, Maryland, like a number of other states, had a program for setting what hospitals could charge. And Maryland uniquely was able to include Medicare in that and Medicaid and really be truly all payer. So there was a commission in the state of Maryland that essentially set the rate for what hospitals were allowed to charge. Now, it's really important to understand this point. It wasn't that they said, like, here's the price for an appendectomy anywhere in the state of Maryland. They gave a different rate card to each hospital based on their costs, based on whether they were a teaching hospital, based on a few other factors. And but every payer paid off that individual hospital rate card. So if an appendectomy cost $10,000 at Johns Hopkins, that was the rate that Blue Cross paid. It was the rate charged to someone without insurance. It was the rate that Medicare paid, plus or minus a little bit. Everything is a little bit confusing, but I would just say that that's the easiest and most clear way to understand how Maryland's system worked. And it worked like that for many years. Now, what happened starting in really about 2010 was that there were a bunch of interesting experiments that were being done with how to use rate setting to design other payment approaches. And the reason this was done is that rate setting had some really great advantages. One of the things that it did for all those decades was it helped pay for the care of the uninsured. There was like a 7% charge on every single bill. All that money got pooled in and it went back out to the hospitals that were caring for the uninsured. Another great thing was medical education expenses were built in for certain hospitals and all payers paid them, not just Medicare. And so there were other innovative quality programs, different things that were done. But it still wasn't helping some small rural hospitals do well because they were seeing declining volumes. And it was a fundamentally fee-for-service rate-setting system. There were some experiments done where the rates were basically built into global budgets. And the way that works is these small hospitals negotiated a budget with the rate-setting system and got to change their rates over the course of the year to hit the budget. The way I would explain this to people is I would say, like, say the budget was $100 and they were expecting $10 per admission, then they were allowed to charge on their rate card $10 per admission because they thought that it would be, they were expecting, they would be expecting 10 admissions, they could charge $10 for each one to get to $100. But if they were getting more, they'd have to start charging less. Or if they were getting fewer admissions coming in than anticipated, they'd be able to charge more. And at the end, they'd still get that $100. So that was using rate setting to accomplish a global budget. And we saw some really interesting things in that the hospitals started doing things differently. They started asking, how can we keep people from coming into the hospital? And in 2014, not 2019, the whole state shifted over to global budgets. There was an agreement with CMS for Maryland to control all hospital costs and beat the national rate of growth. And the way that Maryland would accomplish that would be by moving the hospitals to global budgets. That was something I was very involved in negotiating. There was a second model that was approved for, I think, around 2019. And that more explicitly talks about the total cost of care. I'm sure we'll get into this more, but also has this aspect of hospital global budgeting. So that's kind of the system. And the way that those budgets are made are kind of like that initial pilot. The hospitals have some ability to move their rates around in order to hit a budget that's negotiated with the rate setting commission. And that gives a very different set of incentives to the hospital, which have very important, I think, implications for health and not just cost control.
So that's really helpful, Josh. Why don't we bottom line it? Give us the headline bragging rights for Maryland in terms of how well this model has done. How do we know that it's achieving great results? And what can you tell us about those results?
Sure. So those first 5 years, starting in 2014, Maryland hit all the benchmarks, the major benchmarks that were set up with the federal government. I think the savings number was about $1 billion, close to $1 billion. And that was not just against the Medicare trend, but with a matched control that was done by RTI. Looking at that, we saw substantial reduction in readmissions. Maryland came from, I think, above the national average to below the national average, improvements in quality, and significant declines in preventable admissions, which was one of the really important, I think, community health aspects of the model. And, there's also some obvious points about how the model has maintained a lot of support. I mean, there are not that many models in health that achieve their goals, were proposed by a Democratic governor and approved by a Democratic president, reproposed by a Republican governor and reapproved by a Republican president, and really maintain an enormous amount of support. So not just in the hospital industry, but among different groups of patient advocates and outpatient groups, and just generally, people in Maryland feel a lot of pride about the way the healthcare system is organized.
Now, somebody listening and hearing this description might say, okay, so that's the hospital side. Might that sort of system, though, encourage physicians or others who aren't covered directly by hospital budgets to find a way of revenues flowing into them in some ways to compensate for the fixed hospital spending? And so what's the net effect on total spending in such a system?
Sure. So in Maryland, we did see a little bit of that, but the net effect was still very, very positive. So what you would imagine is that some things don't need to be in the hospital. I mean, in a fee-for-service world, the hospital is like a magnet for things, especially if you can add a facility fee on top of whatever else you're doing. So suddenly there are all these mammograms being done in the hospital. Do mammograms really need to be done in the hospital? Probably for most people, no. But if you can throw on a big facility fee, it's like you're printing money. Now you put a global budget on, why are we doing mammograms in the hospital or so many mammograms in the hospital? You can move that off. So that will move some of the cost off, but in the process, it can just generally deflate the balloon. And what you get is some shift from hospital to outpatient, but not enough to compensate for the substantial decline in hospital spending. So in Maryland, I think the overall spending on hospitals was down like 1.3 or 4 billion, and then it was a net $800 million, something like that, total cost of care. And that's just looking at Medicare. But we're an all-payer state, so we saw substantial improvements, not just for Medicare.
Let's focus a bit, if we could now, on Medicare, because one of the things that we often hear in some of our discussion, we try to talk about Maryland and say, oh, they have all those Maryland Medicare dollars in their system by special agreement with the government. In fact, a significant amount of dollars, more than they might get if they were not under Medicare, if they weren't in that system. Can you talk about whether that's true or not, and your reflections on that?
Sure. So I think what people are referring to is the fact, like I said earlier, that in Maryland actually set the rates that Medicare paid. And the way I would describe this is in like 49 states in the District of Columbia, Medicare would pay Medicare rates, but in Maryland, Medicare would pay Maryland rates. And that's pretty good deal. It's in a sense what Maryland did have in the past. I'll explain why I don't think it's quite the same now, is a kind of key to the federal treasury, right? You can charge what Medicare is. Now, that key came with two strings attached that are very important to understand. One of them is that the rates charged had to be the same among all payers. So if that rate setting commission had come together and said, it's kind of harder to take care of patients 75 and up, let's double the rates for them, Medicare would have backed out. They would have said that's not fair. As a way to do it. And the other one, and just what that also meant was that there's no ability to cost shift between payers. The hospitals have to live with the rates, what they are. So it's not quite the same in other states where Medicare is less, but suddenly they're charging 5 times the amount to other insurers. The second string attached was that Maryland's rate of growth in the prices it could charge per admission couldn't exceed the national rate of growth in the Medicare program. So I'll say that again. The price per admission couldn't grow faster in Maryland. So the idea was federal government was saying, okay, Maryland, you can have somewhat higher prices, but they can't grow as fast. And that was one reason why Maryland had pretty slow price growth. In fact, at some points, the slowest price growth in the country. In the end, Maryland's healthcare system wasn't the most expensive if you looked at all payers. I think Maryland was 15th to 20th. But for Medicare, it was higher because the rates were higher in Medicare. So Medicare maybe didn't get that great savings. Overall, Maryland didn't look like Massachusetts for cost. So it was lower. Now, that's all before we switched to global budgets, and when we switched to global budgets, we weren't just talking about the prices per admission. We're talking about total hospital spend and actually real savings, not just savings that on price, but not necessarily volume. This is price times volume savings. This is the real thing.
This is inpatient and outpatient.
Inpatient and outpatient hospital spend. And so, and total cost of care monitoring. So we're seeing serious, reductions against the national trend, serious reductions against matched control groups. And ultimately, the goal is really to bring Maryland down within Medicare, but while doing that, bring the entire cost structure down, because unlike other places, you bring Maryland down, you bring down Blue Cross, you bring down, Kaiser, you're bringing down everything. And so the goal is really to have a much more sustainable healthcare system. Medicare is, and has been paying a little bit more than it otherwise would, but it's for a goal that is very, I think, worthwhile. And that extra that Medicare is paying is going away.
So in Maryland, the game is significantly focused on Medicare. In most other states, including Massachusetts, the game is focused around Medicaid and trying to get more money out of Medicaid through what's sometimes referred to as DSH funding, disproportionate share hospitals, or the various Medicaid waivers like Section 1115, 1115 waivers. Massachusetts has gotten enormous additional federal money over a good 25 years now from the federal government. Does Maryland also get special deals on Medicaid, or is it kind of one or the other? How is that?
Yeah, it's not at all like Massachusetts. Massachusetts has, I think, done better in that regard, or done more in that regard, I should say. But I think it's important, and to say that the way that Maryland's financing is structured now is that it really isn't a move to get more federal money. I mean, it's a move to be more organized. I think that there might be some fair criticism of the rate setting system when it was fee for service, that it was quite generous on the Medicare side. It's getting less and less generous on the Medicare side with the global budget, but it is creating such a different environment for hospitals that I think people are really paying more attention to Maryland now, that it isn't about just the financing. It is about, what healthcare can be doing.
Josh, you've trained in Massachusetts. You worked in most of your career in Maryland. And one of the things, I'm wondering is when you are in Maryland, where you have, I think it's fair to say, two major academic medical centers, Johns Hopkins by far the largest, and University of Maryland. And we in Massachusetts, as you know, have a whole slew of academic medical centers and such. How different, for example, is Maryland's total environment in that way, or other aspects structurally that make your model's ability to be replicated in other states like ours impacted, would you say?
Well, when I was, I actually grew up in Maryland, and our Maryland module in social studies was called America in Miniature. We have rural areas, we have urban areas, and the healthcare, we have academic centers, we have suburban hospitals, we have some small hospitals and a couple really tiny hospitals, but not that many. But we have a little bit of everything. And so I think that there are a lot of potential lessons. Now, it's hard to snap your fingers and turn another state into Maryland. And there are a few reasons for that. I think that we're probably looking at a healthcare system inspired by the Maryland model rather than exactly the Maryland model in other places. Something that I think is important to think about is to think regionally in other states. What we've seen, Pennsylvania has adopted global budgets in rural areas. I think rural areas are particularly easy to think about global budgets when you don't have rate setting. But there are also some urban areas around the country that are considering that a global budget approach without rate setting explicitly. But I think it may be hard to do a whole state because you've got to figure it out without rate setting across multiple different kinds of systems.
Do you think there's value for a state, and you said both Maryland sort of started this way, and I think, as you mentioned, Pennsylvania, to maybe look at smaller, maybe more financially challenged institutions, like in our state, who often have to go to the legislature every year or two to get additional bailout dollars. If those are the sort of a ripe group to think about such a concept for?
Exactly, for multiple reasons. One is that, the state government in that case for bailout dollars is really just spending money to keep a healthcare institution afloat. They're not spending money to invest in the health of the community. That's fundamentally why we have hospitals, and what you'll see is some of those areas with the most distressed hospitals have the most distressed populations. Think about the rural rate of suicide, the rural rate of overdose, the chronic illnesses that can exist. And when you're just paying to keep the doors of a hospital open for infrastructure, you're not really tackling those problems at all. Now you switch to a global budget and you create a very different incentive for the hospital. The hospital does better financially the fewer people that need preventable services. And so, suddenly you might have a pulmonary rehabilitation service you didn't have before. The economics of different things. It's not just what can we bill, but what can we prevent by doing things? I was involved in a meeting with the Pennsylvania CEOs thinking about going into the Pennsylvania rural model. And I brought a couple Maryland CEOs. And I'll just say in this group, they had a particular demographic, all the CEOs. They all kind of look like each other. I might describe that as the 35th reunion of the Penn State offensive line, if you know what I mean. It was just a certain look to them. They were pretty substantial people, but they sounded very differently. And the Maryland people, the guy said, look, I used to meet with my COO and every day we would say, or CFO, and say, how do we get more patients in here? And now I'm saying, how do we get fewer patients in here? And we've created nurse on the corner, and we're giving out food, and we're checking people's blood pressure, and we're doing extra follow-up visits, and all these things I never thought we'd be doing before. And the, Pennsylvania CEO is just like dumbfounded on the other side of the table. Like, I mean, why? That's not how I grew up in the hospital business. And so I think that, anyway, I think that there's a lot of interesting opportunities in rural areas. And that if you can find the leadership to see the big picture, this isn't just about cost. It's about doing better and aligning the health of the institution with the health of the population. Then you can really get some excitement going.
So Josh, Dr. Zeke Emanuel from the University of Pennsylvania was speaking to our Mass Association of Health Plans last month. And he made the flat out statement. He said, Massachusetts and other states should look at replicating the Maryland model. Massachusetts started its own model back in 2012, which has a soft growth target for the state. And it seemed to work very well for the first roughly 8 years. And now it's showing signs of weakness, and we're having our first moment of truth in terms of it. But I have to say, we had an earlier period between 1975 and 1991 when we had old style, heavy-handed rate regulation. And I was in the legislature at the time. It was enormously full of political conflict and gamesmanship. And it drove the legislature crazy until in 1991, the legislature threw up their hands and deregulated the whole thing. Is there something different, you think? You lived in Massachusetts and Maryland. Is there something different about the political culture and environment down in Maryland? Or do you think a state like Massachusetts could take elements of your model and apply them in an effective way up here?
Yeah, well, there are a couple of aspects. I think one thing is that there is trust between the hospitals that's been built up over 40 years of doing a different kind of system where everybody kind of shared a risk. In other words, if there was a big problem with the system, it affected everybody. And so people collaborated. And even though they were competitive in some ways, there was this basic collaboration between the hospitals. And one way to see that is that Maryland has, I think, the most advanced and successful health information technology, health information exchange, data sharing service. It's very easy to look up patients in other hospitals, but there are all kinds of different services. Somebody's discharged from one hospital, shows up at the next hospital, immediately everybody gets notified. Any primary care doctor can get a snapshot up to the moment of where all their patients are, who's been in the hospital the most. All that's from data sharing that just relates to this spirit of cooperation that exists between the hospitals. The second thing is that there is some comfort with regulation and losing a little bit of control, and that has come from, having a professional staff, having a appointed group that oversees the rate setting commission, of which several people are kind of put forward by the hospitals, but not the majority, and a basic consensus in the state that we want the system to succeed and we want our hospitals to succeed. And so there are some unique things that it's hard to invent 40 years of history and trust in another state. I think that's partly why, I appreciate the idea, and believe me, if there were a state that wanted to go to Maryland, I would be all, in helping them. I think realistically, what you see is that there's some hospitals that have done pretty well under fee-for-service, and giving up a little bit of control to an outside entity is not the top of their agenda, frankly. And they're going to be pretty resistant, and they're going to use every political tool that they have to avoid some kind of, constraint on their revenue growth. And so I think that the way to start to gain confidence with this is perhaps through regional, you're getting my opinion, through more regional approaches where people really do have their backs up against the wall, but there really is a positive value. It's not just about avoiding the pain of bankruptcy. It's about the positive value of being able to roll out new programs to the community, to be about prevention, to be allied with, people against overdoses and suicides and other things like that. I think that makes this bigger than just about, costs and money moving around. And I think it's a political strategy, not just a public health strategy.
I want to build a little bit though on what you said, and I hear what you're saying from a public health even social determinant perspective. But the issue of the day in our state, if you ask the health policy commissioners or other stakeholders, they say, gee, the 8-9 year experiment that we've been having is starting to fray, as John says. Hospitals are asking for double-digit price increases with their commercial insurers. We still have a significant price variation where our largest, most prestigious systems get paid much, much more than the average. We now have Children's Hospital and Mass General Brigham and Faulkner adding a combination together of 250 inpatient beds as they rebuild their physical plan. And they have about $800 million of ambulatory care expansion proposals into suburban communities, which will gather more market share for them likely and possibly referrals. Are global budgets a way to deal with some of that challenge that people who are worried about sort of the continuing spending pressure that happens when you have systems like that have, as you say, increasing revenue desires? So,
yeah, I mean, I don't think that global budgets are going to avoid some of the hard questions that kind of revenue growth poses for an economy, really, and can the economy really support that level of spending on healthcare services above and beyond what you really need to spend? That I don't think there's like a way to avoid some difficult, issues there. But, I think you can look at Maryland and say, Johns Hopkins has thrived under global budget. It's done fine, and it's thrived under rate setting. That regulated entities actually get some protection from certain types of things that can happen to them, and ultimately, maybe there's all this extra money for big systems just to wring out of everybody else. But, at some point, maybe the music starts to stop and that creates an opportunity. I think we might have missed a little bit of an opportunity with COVID, as the volumes went way down, to a large extent, the federal government wrote a check to the healthcare system. But will volumes come all the way back up? Will there be, different types of reasons why people aren't as sick from infectious disease because we're all wearing masks, or something else happens that actually the just fee for service engine just can't keep running? I think that the opportunity is there to say to people, like, the alternative isn't, you're not a shark. It's not move forward or die. There you can be a different kind of species and think about your relationship with your community, still doing cutting edge work like Mass General and Brigham need to do, and other, academic, Beth Israel, Deaconess, everyone. But, but at the same time, really feel like part of your responsibility is to make your communities much healthier and shift gears to a different type of reimbursement for the vast amount of hospital care that you're providing.
We know the research innovation efforts of our hospitals are incredible. And while they get grants for a lot of it, at least in our state, they get some of the ability to spend monies in that area off of patient care dollars. Is the global budget set up in such a way, for example, that Johns Hopkins is able to glean additional monies, which from the global budget for patient care, which they can, in essence, are using for expanding research budgets and the like, or is that not clear if they're able to do that?
Well, it's a somewhat complicated answer. It's not the same as a fee-for-service hospital that's just making a lot of margin and just turning margin into whatever they want to spend it on. But there are special provisions for innovative health services that create support for continuing and expanding them in hospitals like the University of Maryland and Johns Hopkins.
Okay. Well, Josh, you've taken us in different directions with your answers as we tried to pry with you. We really appreciate your coming and joining us today. And I think our audience is really going to have a lot to think about after they hear you describe what's going on in Maryland for a good number of years now. So thank you very much for joining us today.
All right, take care.
Thanks, Josh. Thank you.